to all of you joining us this evening. Welcome. Just to make sure that you've got the right webinar, who knows how many webinars there's going on these days. This is on Cancer and Budget 2021. What does it all mean for you? So we are going to be starting soon, and my name is Azrul Mokhalib from the Galen Center for Health and Social Policy. This is a series of webinars where we discuss how the various policies and actions implemented during this period of crisis have impacted the management, control, and treatment of cancer. This series is powered by the Pharmaceutical Association of Malaysia. So it has been a long couple of months since March. The imposition of the movement control order, the conditional MCO, the recovery movement control order, back to the CMCO, and now we reach the end of the year. For our colleagues at the Ministry of Health and Public Healthcare System who have been on their feet responding to the COVID-19 epidemic since last December, before it even had a name, it has been a long year for them. We're just beginning to see the effects of the COVID-19 crisis on cancer care. Many patients have faced troubles with referrals and rescheduling of their treatments and surgeries. There have been many deferments. There have been even defaults out of treatment. And overall, it has been a challenging time for cancer care. On 6 November, the Minister of Finance stood up and presented the federal budget for 2021. The health budget received an allocation of around 31.9 billion, a 4.3% raise from 2020. And it also appeared that there were deep deductions into the non-communicable disease budget, which included cancer. However, the government later stated that the treatment allocations had in fact been consolidated into a couple of line items and that there were no decreases in funding. It's now a month later, the budget has now been passed by the Dewan Rakyat and will soon be passed by the Dewan Negara and later signed by the Yang DiPertuan Agong. So what does it all mean for us? And for you especially, those living with cancer. With us today, we have a few individuals who definitely are well suited and qualified to speak on the subject. The first we have with us is Dr. Madeline Burma, who is a former academician with the University Kebangsaan Malaysia. She is a pretty well-known economist who, because she comes from East Malaysia, has very much the welfare and concerns of East Malaysians in her heart. And we are very fortunate to have her with us to speak on the economics of what does it mean in terms of the budget 2020, because sometimes it's really confusing, even for economists themselves, it seems, what these budgets all mean, and most importantly, how does it translate to actual figures and fundings for programs such as cancer on the ground. We have with us Dr. Murali, who is the Medical Director of the National Cancer Society of Malaysia. He is one of the, I think, more famous individuals in the cancer scene. I think, would that be correct, Dr. Murali? A bit, yes.
Infamous, more like it.
Infamous, definitely. So now we were also going to have with us Ms. Ranjit Singh, Ms. Ranjit Kaur, who is the president of the Breast Cancer Welfare Association. But unfortunately, she at the last minute wasn't not able to make it with us, but she has recorded a message for us, which we will play later on in the discussion today. So welcome to both of you. We will be taking questions during this discussion. For those who are interested to ask a question, please use the chat box and send those questions over to me, and we should be able to address them. Please, at any point of time, not wait for the Q&A segment, but just send in your questions and we'll try to get them answered by our panelists this evening. So without further ado, let me invite our first panelist to give a a 5-minute opening statement or presentation on that point that they would like to talk to us about, and then we'll proceed on to our discussion. So again, for our participants of this forum this evening, please do send your questions via the chat channel, and we'll try to get your questions answered by panelists. So let's start, shall we? Dr. Madeline Verma, the floor is yours. Go ahead. It's okay.
Okay.
Yes, we are. Go,
okay.
Go ahead. Yeah.
All right. Thank you very much, Azrul. Well, I have something to share here. Economists, somehow they cannot survive. Okay. Thank you very much, Azrul, Gallen Center, Dr. Mu. Wow, that's a mouthful. Murali, I can call you just Murali. This is an honor to meet with the introduction by Azrul. So I said I am really in the midst or with the person himself. Okay. All right, can you see this? Can you see my PowerPoint? Can you? I hope so. Is it okay? Yeah, okay. So thank you very much. Budget 2021 and cancer. Madeline, I am with the Fellow Academy of Sciences, Malaysia, although I also hold another position that is I'm with the, what do you call, SOHAKAM, Human Rights. So Azrul, you're correct when you say that my heart is with Sabah and Sarawak, but that's being part of Malaysia, that doesn't mean that I'm trying to kind of say I'm only focusing on Sabah and Sarawak. Now, I would like to put the context of my discussion today. My training is I've always done development economics. So somehow or another, when Azrul invited me, do you want, can you do something on budget 2021? I said, okay. I forgot that there is another part to it. There is cancer. And I said, oh my God, what am I going to do here? But nevertheless, I would like to share some of the views and thoughts regarding the budget. So this is basically what I'm going to discuss today, Azrul and members participating in our program today, okay? So basically, what is this budget 2021? What are the major strategies? I think by now, all of you are overwhelmed with budget. And of course, now as you all have, I mean, you know that we are already at our, there has been approved, the third stage, and so they will be brought up to the higher level. So we hope that it will be approved as soon as possible. Then I will focus on budget for MOH and what are the issues, the challenges, and the conclusion, okay? Now, we economics, we need to survive with graph. Now, many of us realize that we have heard a lot when people talk about flattening the curve. Economists look at not just flattening this COVID curve, we are also talking about flattening the economic curve. Now, here, the red part here, if you notice here, if we do not take any measures, what will happen is that this will result in what we call the healthcare system could not manage. So what happened is that the increase in the number of COVID cases will create what we call, if we don't have anything, it will have an impact on the economy. Okay, so there is a need to ensure that we flatten it by doing what we call social distancing, hand washing, and blah, blah, until and when vaccine is found. So we were told that vaccine had been found and soon it will be rolled out and we will have it soon, okay? So this, in a way, will bring out what we call a flattening of the curve, the economic curve. So I'm focusing on economics today. So basically, now, in view of the issue of the pandemic, as we know, if you notice, we have tabulated Malaysia's budget from 2010 to 2021. So if you notice, this is one of the biggest budget that we, the government have allocated, and it is very much related to the COVID, to address the issue of the COVID. So if you notice from 2010 to 2021, and we have here another very high, there's a sharp increase in terms of budget. And this is, if you notice, this is related to the, what we call them, 2018, 2019. There was a crisis, the global crisis, which started in the West. Now, if you notice, the budget here, the budget is allocated. How is it being allocated? There we have the COVID fund, and we have the development expenditure, and a big chunk of it is on the what we call is the operating expenditure. And this has always been an area of concern. It seems that a lot of times we always argue that why should operating expenditure, this one includes, the payment for gaji, all the expenses incurred in paying of emoluments. But this one is basically that is going to be spent. Okay, now let's just move on to the next one. So these are some of the major strategies. The first strategy is basically pandemic and public health. So we expected a big chunk of the budget to be allocated for healthcare. So, and also to address the pandemic problem. Secondly, this is the welfare of the vulnerable groups. So I think this is very important, and I have always focused on this group. Only today, suddenly I'm looking into public health, but it is interrelated. Now, who are the vulnerable groups? Number one is those with what do you call the OKUs, female-headed household, those in the rural communities, in the interior, because in Malaysia, we don't only have rural, we even have interior, like in some part in Sarawak, where it takes you like 2 to 3 days walking, walking 2 to 3 days only, then you arrive at long houses. We're not talking about cancer yet here. I'm just giving you the context. Now, number 3, generating and retaining jobs. The other one is the issue of the inclusiveness agenda. Number 5, ensuring the well-being of Rakyat. And the other one is you talk about continuity and economic resilience. Now, if we look at all these 6 strategies, the main focus, of course, number 1 is Rakyat. Number 2, small medium enterprise, that is to generate economic growth. And number 3 is the national economy. So number 1 is the Rakyat. Now, if we look at health, although this pandemic, what we call the budget, started off what we call is to address the COVID-19 health, but basically public health is only one part of the strategy. But we would like to see whether when we talk about the vulnerable groups, whether, because it is all interrelated, okay? So these are the 6 strategies. Now, I think I'm already almost like 5 minutes already. Now, this is how the budget is going to be allocated. You just shout, Azrul, knowing me, Pensyarah and Iban, you can't give them the mic. Now, if you look at in terms of budget, the highest has always been Ministry of Education. It has always been Ministry of Education. Then we see that there was 31.9 billion, was about 32 billion was allocated to the Ministry of Health. And you rightly mentioned there was an increase of 4%. And I did read your report and how you commented about, yes, although there had been an increase, but once you start diving into the details, there are issues that need to be addressed, okay? So Ministry of Defense, this one, I don't know what are we buying, I also don't know. But Ministry of Transport, rural development equally big, yeah? So, okay. Now, this one, I got it, definitely, most of you have access to this, code blue, of course. And this is a very interesting budget because majority of those on the internet always cite this budget. So I think the Ministry of Health really had a tough time trying to look at this, Rakyat Jelata only want to see this, they want to see this. Many of us don't even know me. I'm concerned about nephrology because, I have, I have, what do you call it? Kidney problems. So I know that. Other than that, there is always, I know, psychiatry and mental health, oncology is where I think, please correct me if I'm wrong. This is where the cancer is. So for those of you who have not seen this is easily accessible on the internet. And that's a good thing about our data nowadays. It is easily accessible. So if you notice, there has been a reduction, okay? So this is where the budget is something that we are now, we need to look carefully. As I said, we need to dive deep into it. So the budget 2021, yes, there has been an increase. But if you look at the budget allocation from 2020 to 2021, there has been a lot of reduction, okay? So this is something, and I think Azrul, you have been fighting for this. You, in fact, they cited you. Oh, so I said, oops, Azrul is there, okay? Now, another thing is, these are the budget increase. So we see there has been an increase in terms of health facility, PERKA, B40. Okay, this one I happy lah because I'm with the B40 and everything. Okay, then we look at it, emoluments. There's a big increase. These are the things, contract staff, management of food safety and quality, and then you look at all this. So if you notice here, there's a big chunk here is emolument. So including contract staff. So I do hope that when we look at this, the human resource component is very much looked into, but I'm not too sure about the healthcare and things like that. This is really something for our medical doctors to look into later. Now, if you look at the thing, yes, I always use this term. We meet the targets. The budget is basically, if you notice, it is, I think, a big chunk of it, although we see the strategy number 1 is to address healthcare. But the big chunk of it, if you ask me, it is basically to address the economic issues, economic problems. So if you, there was a big concern about budget deficit because we are very worried about our ratings, because right now we had been downgraded. So we are talking about a bigger agenda, which is the national economy, the small, medium enterprises, and blah, blah, blah. So we see, yes, we meet the targets. We will be, in terms of budget allocation, yeah, we do meet the target. But to a large extent, if you ask me, there are a lot of people who will be missed by this budget. So I'm not just focusing on in terms of what you call health. I will highlight some of the things later. So yes, there will be reduction in terms of the budget for non-communicable NCDs, cancer, cardiovascular, kidney disease, curative care, and public health. So this, I'm sure you noticed in our budget just now. Okay, and what are some of the challenges? I'm towards the end of mine. Okay. My concern as a person who has been doing poverty and doing inequality, these are some of my big concerns. The marginalized people of society. When you talk about a budget, there is always the dollar and cent. The low income group, our OKUs, the rural and interior. I cannot imagine if a Penan were to get cancer. I'm talking about Penan, I'm not talking about Punan. Punan are those who are settled. Penan, God knows where they are. They are very mobile, and they are nomadic. So even I have never met them. The real Penans, the one that I met are those in the long houses. So this one have slightly better access to healthcare, but rural healthcare, and the indigenous communities. Another issue that I would like to highlight also in terms of social security, because this is related to the cost of having access to cancer. When you talk about cancer, so this is our social protection. Yes, we do have social security program, pension, EPF, and then we do have social insurance, and then we do have social assistance individually, subsidies, zakat. Now here, this is the healthcare. Okay, the healthcare. So we have medical goods, healthcare program, and blah, blah, blah. So this is the social protection in Malaysia. Now, there are still people who, one of the biggest challenge for us now, I just had a webinar recently about our social protection in Malaysia. How many people are protected? Okay, all right. So zakat, the Muslim, but also they are, I think they do have some allocation for the needy, Okay, so that's my few last point. Now, I got this from a journal. The cost of treating CRC patient at oncology clinic at different stages. UMMC 2012, and this is 2012. I'm sure those of you who are in in this business, I'm sure you know the cost per patient, stage 1, stage 2, stage 3, stage 4. This is from a journal. I think it was cited somewhere here. Okay.
1 minute.
Okay.
Madeline?
Yes. So the last 1 minute. Now, another thing that I am concerned is about the way the budget is being framed. It has always been ethnicity targeted programs in the budget, whereas cancer does not recognize ethnicity, whether you are male or female, whether you are in urban, rural, or whatever. But if you look at in terms of our budget programs, it's quite it's very ethnic based. Yellow is for Bumis, and the gray one is for non-Bumis. But this is not about health. Okay. Now, the last part is about income by state. So if you notice, these are the median is brown, mean is again. So this also will affect their access to healthcare, the quality of healthcare. Not only just access, but also quality healthcare. All right. So the last part is we talk about inequality. So we are here only talking about Gini coefficient is only about income, but actually we can even calculate about, you know, healthcare. So if you notice, we find that there is a wide disparity between rural and urban, and then between ethnic, because it's between 0 and 1. Okay, so it's between, so you only see this, but then we will not go to this. Okay, the last part is that the issue of debt. So the government will always focus on this. So sometimes they tend to sacrifice things in the name of trying to reduce the budget deficit. So what we are worried about is that budget deficit means if they try to reduce it, they might compromise on certain, like for example, social services, because these are the easiest to drop. They will not, you know, like rural development, or even on what do you call this now, health. So these are the things. Okay, I think that is my last slide. So thank you very much. Thank you very much for this one. So I'm not really focusing purely on cancer, but it is really related somehow or another. It is interrelated. Yes. Thank you very much, Azrul.
Thank you, Madeline. If you could just end the share.
Okay. Thank you very much. Let me see. Oh, wait. Stop share. Yeah. All right. Thank you very much.
Well, thank you, Dr. Madeline. It's quite illuminating, essentially looking at some of the points that you highlighted, and those last few slides, especially when it comes to income levels, also possibly affecting access to healthcare. I think that's a very important slide that I think we take it for granted that these are issues that we consider to be homogeneous, but they really aren't. And it depends on where you are located, especially in which state. So for the next speaker, we have with us Dr. Murali, who will be talking to us in his area of specialty, which is cancer care. And specifically, since Dr. Madeline has set the context and the framework of what we're talking about, which is the budget 2020-21, let's hear from Dr. Murali exactly what is it in for cancer. Go ahead, Dr. Murali. You're muted.
Okay. Okay. So sorry. Good evening. Thank you so much for having me on this evening. And I think you were quite correct, sir. So what Dr. Madeline did is very kindly kind of give us a very broad picture of what the budget's doing. So that I was actually concerned as she was putting up the slides. I was worried whether we were going to be talking about the same things. But I'm very happy to note that, you know, now what I can really give you is the slice right down the middle in terms of cancer. So I'm just going to kind of highlight certain things that seem to be there in the budget for cancer, the good, the bad, and then the ugly. And hopefully then we can look at it together and kind of hopefully think of what this means for us over the next year. So in terms of for taxpayers, I think one of the good things is there's a bit of tax relief for vaccination. So now for individuals, spouses, and children, there's a relief limit of up to 1,000 ringgit. And really, in terms of the cancer context, this can help you cover a bit of your hepatitis B vaccines that prevents liver cancer, some parts of the HPV vaccine, which is really one of the biggest kind of protective elements in place for cervical cancer. And so those are two big things that you can put up. It's the first time we've ever given tax relief for vaccination, and of course it's on the kind of the back end of perhaps paying for COVID-19 vaccination individually. But you know, it's like I said, I'll tell you the good, the bad, and the ugly. So in terms of medical expenses relief, that's also kind of been increased a little bit from 5,000 to 8,000. Now, can this be used to treat cancer? I don't think so. But for a lot of people, diagnostics is not really covered under medical insurance, and so this then can kind of top up that gap. It gives you again a little bit of tax relief for that set of people who are in the screening stage or the diagnostic stage of cancer. There's also kind of this other category of parental care, medical treatment for parents. Again, that will help younger people who are kind of subsidizing or helping out with their parents' medical expenditure. There's a bit of tax relief from that point as well. Also, now I think Prof highlighted a little bit about this. So there's very specific health-based financial risk protection measures in place, put in by the previous government, and then it's good that the current government is actually continuing on these measures. Actually, there's a lot of concern from us in the kind of healthcare advocacy that kind of set up, because we're concerned on some of these good programs. You know, when a new government comes in, they kind of do not want the branding associated with these programs. Thank God, a little bit of sense, I think, prevailed. What's good is the My Salam continues. The My Salam is the critical payout for when upon diagnosis of critical illnesses. And the good thing is cancer is one of those critical illnesses. You get, I think, an 8,000 ringgit payout. And so again, it's not that helpful if you're in a private hospital. In fact, you can't use My Salam in a private hospital, but for really low income patients in the B40, 8,000 actually settles quite a bit of your treatment costs in a government hospital, and that's kind of important to note. So it kind of helps you decrease the hurdles in terms of financial catastrophe that you will face in treatment of cancer. What's also kind of, and I think Dr. Madeline kind of highlighted this as well, is the 50 ringgit voucher to purchase Perlindungan Tenang. That's also accompanied by this exemption of stamp duty on the annual premium of Tenang products. Really, these are kind of very basic products for people in the B40 categories, but it's hopefully kind of driving them to purchase insurance, which will give them a little bit of an edge in terms of financial protection, especially when they are diagnosed with things like cancer. The other really good news is, and this was actually of surprise to me, I really thought they're going to kill the Peker B40 program. Surprisingly, they continued the program and they've put quite a bit of funding into it. Peker B40, for those not in the kind of loop, is very helpful because it's for B40 patients. It's useful for screening for chronic disease, including certain cancers, but more importantly, for people who are subscribed onto the program, you actually get access to a lot of medical devices, and this may include some of those medical devices that are helpful for cancer as well, also within the management of the disease of cancer. So that's kind of an important program to continue keeping in place. Good that that's on during this budget as well. Now, what's in terms of financial assistance to the vulnerable? Again, quite a few patients, cancer patients, because as you all know, cancer patients at a certain stage, when they're ill enough, they can actually apply for disability status. And they can actually obtain disability status for people who are that ill. There's a bit of an increase in monthly aid. Again, like I said, I mean, I'm not making a judgment on whether 250, 300 ringgit is adequate for anyone in a month. I'm just telling you what the budget has put into place at this point in time. So there's a mild increase. And also there's a bit of an increase in terms of allowances for carers or for OKU, disabled individuals or chronically ill patients. Again, this is a pocket that includes cancer patients. So it kind of may help to ease a little bit caregivers for cancer patients. There's also an incentive allowance for disabled workers, quite a few, I mean, again, not terribly significant, but there is an increase. So I think one of the things that I think Dr. Madeline quite rightly mentioned was, whenever people talk about slashing expenditure, it's always the vulnerable sectors kind of financing which gets cut. And on paper, again, it's a long to 2021, a lot more things to come, but at least on paper at the outset, this budget actually kind of gives a bit of allowances to these categories of people. And there's an honorarium for volunteers under this home health services program that goes up quite a bit as well. So the idea is hopefully to mobilize a little bit more volunteers for chronically ill patients and kind of leverage on things on how to say their goodwill or their intrinsic motivation already inherent to kind of drive them to do a little more for chronically ill patients. Now, in terms of female-specific cancer screening, they've actually, the budget actually provides for 10 million, in terms of cervical cancer screening and subsidized incentives for mammograms. This wasn't in last year's budget. In the 2018 budget, there was a 20 million allocation for this. So it's a reduction in terms of when you compare to the 2018 budget, but compared to last year's budget, in which it was totally missing. So again, some hopefully move forward. I don't know where this money is going. I think quite a lot of people are unsure as well. The idea is, I think that it will go to LPPKN as it did previously in 2018, and then LPPKN will be kind of the agency that actually runs the programs related to cervical cancer screening and mammography early detection of, I think, again, this is something Dr. Madeline was alluding to earlier. She was pointing out the cost differences when you diagnose different cancers later and later. So we're still putting in some money, hopefully, to detect these two big cancers affecting women early, hopefully. So now, this is a bad thing, and I kind of want to put this up because I think there's quite an undermining of tobacco control strategies. As you know, tobacco is directly related to more than 10 types of cancers. I think it's about 13 or 14 types of cancers. And the fact that we are actually allowing, now by this act of imposing an excise duty on all these kind of electronic, non-electronic cigarettes, what we're actually doing is we're legalizing them. And what you're now allowing by getting these devices into the market is you're getting a whole new pocket of people addicted to these substances. And now I think last week, we already see, you know how you give an inch and then everybody wants a yard. Now industry is actually calling for nicotine to be introduced into electronic, non-electronic cigarette devices, starting off another whole generation of people who will pick up a whole different set of cancers in about 10 or 15 years time. So loads of fun. With
1 minute, Dr.
Yeah.
Rani.
Yep, sorry. Oh, yeah, there you go. And then I think, as I think Doctor was mentioning just now, I think Azrul's mentioned this as well. So what the slides that Doctor put up earlier was about this, the reduction across different subcategories within the MOH for particular programs. And there was a lot of concern about oncology and radiotherapy. Subsequently, MOH, I think, came back in a series of sessions to kind of clarify that again and again, that they consolidated these drugs and supplies across two specific programs: health facilities, medical supplies, and they say financial commitment for this private concession of medical laboratories and stores. Now, so even if you took that at face value, and like I said, I'm just telling it as it is, and then we'll kind of give our analysis in a bit while we speak. But the worry, the biggest concern is that consolidation always means pooling. Now, pooling means one is siapa cepat dia dapat. Okay, and the second is whoever shouts the loudest gets the most. This is true of even your shared family dinner, as it is with any kind of national spending across many subsectors in the MOH. This is actually precisely why we ask for earmarked budgets, where certain sectors are protected, their funding is protected. And that is a big concern for us overall, because by doing that, by consolidating amidst a pandemic, the worry is that a lot more money is just going to go to communicable disease. And again, everybody will kind of see the after effects of this only in 2022, or even longer. The impact is going to be showing over the next decade or so. So that is really the concern in terms of public sector cancer spending. Could we do better? Of course we could. We'll talk about it in a bit, I suppose. Thank you.
Thank you, Dr. Murali. That was a great and succinct analysis of the budget 2021 and how it links back to not just the issue of treatment, but also in cancer care as a continuum, and where the different aspects of cancer care is affected by the budget. I believe you've also possibly answered one of the questions that's just come in. just so that we are aware that during the Q&A session of the Dewan Rakyat, it was shared that the allocation of health is actually 35 billion rather than the original amount that was indicated. So this is something to bear in mind. So for our next segment, we will be hearing from Ms. Ranjit Kaur, whose video will be played on next. Please bear with me.
Okay.
Hello everyone, I'm Ranjit Kaur, breast cancer survivor and president of Breast Cancer Welfare Association Malaysia. It is almost a year since the COVID-19 outbreak started. People with cancer who are actively receiving treatment and are immunosuppressant are fearful, concerned and confused. The dilemma is which one to fear more, COVID-19 or cancer? There is no denying that the real risk is cancer progression. With no end to the MCO in sight, we wonder how long this crisis is going to go on. Things will never be the same. There are various challenges. Because their treatment was deferred, many cancer patients sought initial treatment in private hospitals with their small amount of savings, hoping that they will not be penalized with a higher cost for consultation, procedures, and medication when they seek the remainder treatment in public hospitals. Unfortunately, the budget for 2021, as presented in the Malaysian Parliament, didn't clearly indicate how much was allocated for cancer. We don't know how cancer is being supported by the government during this difficult and trying time. We understand that COVID-19 has priority, but it is essential that people living with cancer not be forgotten or be considered an issue that can be deferred. Today, cancer specialists are worried about significant drop in the number of cancer screening, referrals and diagnosis since the COVID-19 outbreak in March 2020. It doesn't mean that the cancer rates are dropping. It means that cases are being missed out and people are likely not getting the treatment they need on time. People are also concerned about going to hospitals for treatment, afraid that they could be infected with the coronavirus. When we begin 2021, we will be in a situation where gaps in cancer care have the potential to push back on the gains that we have made in diagnosis, treatment, and survival of people living with cancer. We need to recognize that this is a problem and we need to address it. Funding for cancer should be prioritized. Programs which support early diagnosis and link patients with effective and timely medical treatment should be put in place. Investment in cancer care services, even up to advanced stage of the disease, should be increased to take advantage of advances in the field of cancer treatment. Malaysia has one of the worst 5-year survival rates for breast cancer among the countries in this region. Improving treatment will save thousands of lives, especially lives of women. Breast cancer is the 4th leading cause of premature death among women in Malaysia. Every year, the number of women who die of breast cancer increases. With timely and effective medical treatment, many of these deaths can easily be avoidable. More than 2 in 5 women are diagnosed with breast cancer when they are already at stage 3 and stage 4. We should increase the options for treatment for those diagnosed with advanced breast cancer. We should not leave these women behind. We need to invest and upscale successful programs such as those run by various organizations, including Cancer Research Malaysia, which link women with effective treatment through treatment pathways which are supportive and helpful for both the patients who need treatment and the healthcare professionals. As an upper middle income country, we can do better for women in Malaysia. Thank you for listening.
Thank you, Ranjit. So that's from Ms. Ranjit Kaur, who is the president of the Breast Cancer Welfare Association. So we come to the segment for Q&A and also discussion with you, our participants. I just wanted to start off with Dr. Murali. One of the things that you mentioned just now was how there is now a consolidation of the treatment budgets, and those reductions that seem to be the case are not really the case, because they're all now into this budget line that you highlighted earlier. You mentioned just now, siapa cepat dia dapat. I mean, what does this actually result in terms of actual treatment on the ground?
Okay, so now the problem with consolidated funds is, and we know this across, I mean, historically, this is always happens, not only in the Ministry of Health, it's across any sector, any project. What really happens is you use as a more or less as a as is when needed. So at this point in time, so things like, I think like Dr. Madeline was showing us just now very quickly, things like nephrology, for example, and things like cardiothoracic surgery. You can see the big cuts kind of which show movement. Now, a lot of conditions are multi-pronged, multi-sectoral in terms of health. So you will get nephro patients who are having COVID issues. You'll have COVID patients who are in intensive care and need ICU cover. So communicable disease will tend to, due to its severity and acuteness, tend to take up a lot of immediate resources. So immediately, someone make a call to like, okay, we need to increase money that's going into getting ICU drugs, for example. So this is really going to be how money gets kind of bled away from chronic disease, and cancer is going to be, hopefully, like I said, hopefully we all hope and pray lah. But what will happen is then you will lose money onto cancer, and then somewhere around June or July or August, you will start seeing all these quotas, these big restrictions put into place. For example, for purchase of drugs, or radiotherapy, purchase of radiotherapy, or even radiotherapy servicing of machines. All these things will kind of, you will start seeing them from about July, August till the end of the year. So yeah. Hi, sorry.
And what do you say about the concerns by cancer patients that when they see these adjustments to the budget, I mean, do they see it as a level of concern, or do they think it doesn't affect them? I mean, where do you think is the main issue here? Does it really?
Okay. So in terms of individual patients, right? I actually kind of want to put in this comment, because I think, again, this is something that Dr. Madeline kind of pointed out on a big picture scale. And this is, again, something that's going to really impact this budget. Now, traditionally, looking at this budget is kind of extrapolating that it's all things as usual, similar loads as in previous years. But we're seeing a lot of loss of jobs. A lot of people, along with this loss of jobs, are losing their private insurance cover. So a lot of people are going to be moving back into the public sector for treatment, for management of their cancer. And this is something I think that Ranjit also just mentioned a couple of minutes ago as well. And what you're then going to see is this, immediately there's going to be this huge shortage of funding, which is going to be available already. In fact, I was just telling, instead of putting that money into consolidated, they should be actually increasing money into the NCD kind of management funds, because you expect patients to move out from the private sector. So you get this pocket of patients who from the private sector are going to move. They're really concerned because they are terrified actually, because every day these are people who don't know how they're going to pay for their treatments in the next couple of months. But for people who are in the government sector, I'm really very sorry to have to say this, but for a lot of us who manage in the government sector, there's already this sense of futility. We already like resigned to the fate that okay, we're not going to get drugs, we're not going to everything's going to be delayed. Nasib lah, nasib. You know, that's
Okay.
it's already like not even like worried, scared. It's already like hopeless, going on to gloom, give up already lah.
Well, that's quite grim there, Dr. Murali. I'm certainly, it's something of a concern that we're starting this new year, and this is how we're starting up, especially with COVID-19. But I ask you, Dr. Madeline, you know,
Yeah.
you mentioned there just now in your presentation about how there is an inequality of access, and very much this is dependent on people's income levels. Where you come from, which is Sarawak, people have to travel long distances to be able to access those services which are in towns. So now with what's been happening, do you see anything in the budget that actually allows there for people who are in rural areas to be able to much more easily access some of those treatments, especially for cancer?
Okay. Thank you, Azrul, for highlighting this. See, the thing about economics is that we tend to forget the health dimension. We always look at the, you know, it's about income, it is about employment, it's about, you know, all the other things that we think are, you know, economic factors. Like, so when you invited me to give this, to share this stage, or rather to be part of this panel, I took up the challenge because I really want to highlight this, because a lot of my research in the past, when I was doing a lot of research, visiting rural areas, because most of my research were from the rural areas, the problem has been there for a long time. Now, with the current situation that we have with the COVID, with all the CMOs and all, you name it, the lockdowns and everything, it kinds of, this is a because there is no road at the moment that have access from Kapit to Uni. So when we were there, we saw that a lot of problems whereby the communities have to go to Cebu, which is 3 hours ride away from Kapit, and Kapit is one of the division. It's not even considered a rural area. It's a town center, but even then they have to use the what they call the express boat to go to Cebu. Now that is one level. Now we are not talking even about accessibility from the interior, as I mentioned just now. So let alone about cancer, let alone all the other diseases that we are talking about. We're just talking about basic healthcare. Even that is an issue. Now, when you ask me how whether this budget has addressed that, to a certain extent, they tend to address more of the issue of livelihood, you know, providing income to the community. Now, that's why during the COVID period, the indigenous community were really frightened. I remember Dr. Murali, you were mentioning just now, you know, the grim, you know, it is so doom-like thing. So in fact, the rural communities, they were so frightened, they don't even know what it is. And there was very limited information in our language, okay, in the indigenous community language. So it is either in Bahasa Malaysia or English. So there was a lot of fear. So the only thing that they know what to do, some of them ran into the forest, you know, went back into the forest because they know that is the safest place. This is not only in Sarawak, but among the orang asli. So I am talking about not just about accessibility, but also about information, access to information. So income. Can you imagine, Azrul, during that period, during the CMO, in order for you to cross from one area to another area, and in Sarawak, the local banks, you know, they don't even have banks in all the rural areas. So assessing income, you know, having access to, you know, what we call income and things like that, it's really something. But of course, the government has tried their best to address it through all the different kind of program. But if you ask me, more needs to be done. to narrow the gap between rural and urban and the indigenous communities in Malaysia here. So it is very, very important that we need to address that. Yeah.
Let me ask, Dr. Murali, Ranjit mentioned about investment just now and how we need to look at not cancer as a cost or something of a burden, but more towards investing in cancer care so that people are able to survive cancer and most importantly, go back to their lives and be able to avoid an early death. So where are you on that point, Dr. Murali?
I totally agree with her, sir, because, and this is, I think, not only the narrative around cancer, it's ironically the narrative around COVID-19 as well, in the sense that we could actually do things like, I think, what the outgoing president of the United States presupposed, which is just let COVID run. Why don't we don't waste money on it? You know, those who die will die. Those who won't die will just survive, and you know, things will get better. Everybody will have herd immunity. It's the same kind of idea about cancer. But why are we intervening? Why are we putting billions of dollars into COVID? Is because that each of those deaths, every single person that dies, is a huge loss in terms of both the productivity, the hours, the years of contribution that they will give to the society as individuals. And this is me really speaking on an economic level, not even on an individual level, of how many Einsteins we would have lost, how many astronauts, how many, you know, it's the lives lost that would have meant so much more. And in terms of raw productivity, if you looked at it in terms of dollars and cents, I think today you all put up a very interesting piece on presentism, right? On migraines and all that. Was it today? Also yesterday, I'm so sorry. The days all blurring into one. Yeah, and right. So you could come to work and just not do any work, and then that's a loss of money. So, but in this case, these people with cancer who, if we treated them, they come back to work as normal. And instead, you know, you're picking them up late. Second is you're denying them access to good care, medication, which will enable them to be able to continue life as almost normal. And just imagine all that productivity lost.
Thank you, Dr. Murali. Those are very powerful words. And certainly as a non-economist myself, I agree with you, but I see the economist on this panel also agreeing with you, and she's nodding her head up and down. Dr. Madeline, your comments.
Definitely, Dr. Murali, I totally agree with you. But, you know, when you said it, I said, oh my God, here's a doctor, a medical doctor talking about an economist, because the economists tend to be, people said that you're only measuring, you know, I mean, you're only counting dollars and cents. But in the long term, it is like, for example, economists will measure you from the day you're born, right, up to the day that you die, and then they start calculating. They said, you know, a kind of like you mentioned, one is called productivity. The other one was, you mentioned rightly just now, was talent. You know, the amount of money that when I say talent, I'm not talking just about, you know, people say, oh, talent is just about arts, but talent means every one of us have our talent. We can contribute to nation building. So I totally agree. There are three levels that a person can contribute. First, individually, you know, a healthy person that will reduce the cost of, in terms of health, you know, having to go to for healthcare and things like that. I remember when I was at UKM, we were required, we were expected to go for medical checkup at the age of, by the time you reach the age of 40, they said you must go for medical checkup, because in the long term, that will reduce the long-term cost, you know, to ensure that, you know, your survival, rather than wait until you're 50 and there's so many sickness and UKM have to bear my cost, the cost of, you know, having to pay for my medical care. So I think that's very important. Number one is, of course, productivity when you are sick and things like that. Number two is, of course, as I mentioned just now, you know, talent, and number three is this economists would like to use cost benefit analysis, you know, the cost and the benefit of having a sick person. So in fact, you know, the amount of investment that the government now pays, because you talk about human resource development now, they look into three elements now. In the past, they only look at two. One is education, the other one is skill. Now the government, or rather we realize that in economics, we realize that you need to have the third element, and that is health. So these three elements have been imputed. So when you talk about human resource development, it's no longer just education and skill. Now, the government, the organization, or whatever it is, we need to look into the health element. So yes,
Okay.
I do agree with Dr. Murali just now. It is very important for us to look into it.
Yeah, I think that's a very strong message that because of COVID-19, it resonates stronger. In the past, maybe it was a little bit more complacent, but now investments in health are critical so that in future, we're not only just talking about COVID-19, but we're also talking about other NCDs, not just cancer, but also chronic kidney disease, hypertension, and many other NCDs. But when you're talking about cancer, it really is an investment that needs to be made. And we can actually measure this in dollars and cents from an economist perspective, right? So we have one question from a viewer who's just asking, I think this goes to Dr. Murali, a little bit of a controversial question. Any thoughts on where the country is concerning the use of cannabis for palliative care?
Right, sir. And actually, a couple of good points pertaining to this is the first is the fact that, thank you. I mean, that's a good friend of mine as well. I suppose I should give the the lowdown on that. And the question is quite pertinent because at this point in time we need to start looking at alternatives in terms of possible therapeutics. So this is a good time to bring up that discussion. And again, to kind of draw very, close correlations to the COVID vaccines. So you notice that before this, people weren't talking about a COVID vaccine, but because of this problem now, immediately, there's been development, the huge amount of R&D, the kind of arms race that has gone into development of a vaccine, and you've got it out within 9 months. It's unheard of. So similarly, why not marijuana? Simply because there has been quite a lot of little pockets of work being done in terms of cannabis and its efficacy in terms of use for pain relief. Now, I'm very careful to use this because if not, somebody's going to put this onto the paper tomorrow morning. But what is this? It remains, difficult in terms of evidence because we haven't quite got enough big evidence to kind of show efficacy. And again, to draw parallels to the COVID vaccines, you see this huge amount of populations being tested, huge amount of trials being done. We need that kind of push and that kind of drive to get like cannabis looked at, tested in an effective way. And when it is found to be efficacious, we need to actually roll it in. Again, drawing, it's this beautiful, this COVID time. We can draw all these nice correlations and people can see it immediately. What is this? Traditionally, it would take the FDA between 18 to 24 months to actually approve a new drug, and leave alone a vaccine. Now, wow, can approve in 60 days, 70 days, all unheard of kind of processes. That means people are burning midnight oil. Again, I think even in our own country context, we were talking about NPRA approval for a drug taking, again, months and months. Now, I think we're talking about expedited review and kind of pushing out, burning the midnight oil. People are going to be working far beyond the office hours and kind of putting in the manpower you require to actually push out. So if we could kind of sustain this energy, this drive, this change in system, why not? We could put in application for cannabis use and scientific evaluation committees of the NPRA, our drug evaluation agencies, if they could get that out off the ground, then legislation can kick in as well. Yeah, why not?
So I think the common thread for our discussion throughout this evening is really about saving lives. And I think I want to pick up something Ranjit mentioned just now to sort of give you a chance to give your final concluding remarks based on the theme of saving lives, which Ranjit mentioned and emphasized several times during her video just now. So let me give it to you, Dr. Madeline. In terms, as an economist, we're looking at budget 2021. The focus is definitely in terms of saving lives and in this case, cancer. Any comments, concluding remarks?
Okay, thank you, Azrul. Now, when I look at the budget, when I dive in looking at the budget in a what do you call it, in a more focused mode, when they talk about saving lives, they are actually talking about economics. It's basically economics, putting food on the table. There are people who, of course, we know of incidences, people trying to commit suicide because of loss of job and things like that. So I don't really think it is more about cancer here when they talk about it. But I think the discussion today has brought to light a new way of looking, not just about saving lives in the context of economic, meeting ends meets. Because everywhere, if you hear when the minister, when he kind of discussed the budget, the context has always been about economics. So now I think we need to have a balance, because budget has always been seen as an economic term. So I'm very thank you very much, Azrul, and also Ranjit and Dr. Murali, for highlighting this, because I think this is an opportunity for me to look even from Suhakam perspective, from human rights perspective. This is a very important element, the right to health, quality health, healthcare, and of course the right to life. Thank you very much, Azrul, for inviting me. Thank you.
Thank you, Dr. Madeline. Dr. Murali.
Again, perhaps thank you very much again for inviting me, and really the opportunity to listen to Dr. Madeline today. That's really been very insightful. Given me a lot of food for thought. So in terms of what do we take away from this? We can sit and complain, and we should advocate all that we are doing, but I think it's also a very important time for solutions. I was telling you about the tax relief earlier, and what the government is signaling is that it's not a good thing, but there's a kind of a big signal coming out that, look, we need to kind of take care of our own health. Is this good? Is this bad? It's not a good thing. It's a move away from the kind of socialist heart of the core of our healthcare system, which is very beverage left-leaning kind of system, but it's actually an erosion of social protection. But so we have to kind of put a lot of alternatives into place. We need to kind of put up solutions. We're trying with a lot of other people to put up solutions, build alternative centers for diagnostics, look at other partners to kind of screen early. We do a lot of screening with other corporate partners. We're starting microfinancing programs to look at people buying into drugs. We're trying to work with our colleagues in pharmaceuticals to kind of create access programs for public sector patients. So all these are things that everyone needs to get a move on. And as Doctor was saying, at the end of the day, the most core thing is putting food on the table. So even our colleagues need to work at getting food onto cancer patients' tables. It's a tough road ahead. We just need to get on it.
Well, thank you, Dr. Murali. That ends today's webinar on looking at cancer and budget 2021. Those are fighting words. I think I heard from both Dr. Madeline and Dr. Murali just now. Thank you, both of you, and to Madam Ranjit, who joined us via video, for taking the time out of your Tuesday evening to being great guests for this discussion. To our participants, if you have not already done so, please join the Cancer Care Working Group Facebook page and join the YouTube channel to see the recording of this session and the previous webinars that we organized. So that's it for today. This is Azrul Maut Khalib signing off and wishing you a great week ahead. Stay safe and healthy. Good night.
Thank you. Thank you.
Thank you.